Okay, so we're going to be talking about imaging the endometrium in this next session. I'm going to do a very quick gallop through also the IATA criteria. If any of you are familiar with that, if you're not, that's great. So it's just telling you about the lexicon, and I will be focusing predominantly on imaging of the endometrium via the ultrasound. So we'll talk about the normal endometrium. I want to talk about the role of imaging in abnormal uterine bleeding, talk a little bit about the evidence in postmenopausal bleeding. We'll talk about classification of endometrial hyperplasia, endometrial polyps, cancer, and the role of ultrasound and staging. So that's quite a lot. Let's see if we can get through that, okay? So we know that transvaginal ultrasound is a very reliable discriminator in the postmenopausal setting for people who are at high risk for endometrial cancer. And in particular, an endometrial thickness of 4 millimeters or less gives you a very low risk of endometrial cancer by a factor of 10, both in patients who are and who are not on HRT. And I'll talk about some of the evidence related to that shortly. So I said I would talk about IATA. Most of you will be familiar with IOTA, which is the IOTA group that has worked with adnexal masses, but there is also the so-called IATA group, which came together in 2008, and they also developed standardized terminology for assessing the endometrium and came up with criteria that would be helpful when we're actually describing endometrial pathology. So again, just in the shortness of time, I'm going to go through these slides very quickly. I'm happy to share these with you through PDF or something via Merit in the end if you want. So a reminder that transvaginal ultrasound is mandatory wherever possible to assess the endometrium. If you have patients who have large fibroids who obviously cannot have a transvaginal ultrasound, then transabdominal techniques are fine. You want to ideally do your ultrasound in the early proliferative phase, so that's between days 4 and 6 of the cycle. And then in terms of your technique, you do your standard sagittal from cornua to cornua, and your transverse plane from your fundus to the cervix. So what do we do in terms of optimal inclination? You want to make sure that your angle of inclination is perpendicular to the uterus, and that there is any anatomical changes such as endometriosis. You want to try and make sure that you're not distorting the cavity, you're pressing on the abdomen, and then if possible, when you're looking transabdominally, you want to make sure that your bladder is full as possible. So in terms of measurement technique, again, I know I'm preaching to a converted audience, but you want to make sure that you include both layers of the double thickness, place the calipers at the very edge, and measure in millimeters up to the nearest decimal point. If there is fluid present, you do not want to measure that fluid, so you want to be exclusive of that fluid. If there is asymmetric thickening, again, it's very important to independently measure the anterior and the posterior endometrium separately. If you don't see it, it's very important to say it's not seen or not measurable, because there is a potential risk of obviously overlooking abnormal pathology. So here we have an example in a postmenopausal patient with a little bit of fluid in the lumen. How do you measure it? Well, clearly not in that corner in the top left-hand corner there, because we've included that fluid. We want to independently measure the anterior and the posterior endometrial thickness. So in terms of non-diagnostic transvaginal ultrasound, what do we do next? We have a couple of options. Certainly blind biopsy can be performed if it's something that's of high concern, but saline infusion sonography, which we do a lot of, has a very high sensitivity and specificity for the exclusion of endometrial pathology, and so does hysteroscopy. Hysteroscopy is obviously a little bit more invasive, but can be targeted to perform biopsy at the same time as well. So here we can see that transvaginal ultrasound struggled in this patient who's got very bad adenomyosis to see the endometrium, and so she actually did go on to have a sono as well. So in terms of intracavitary lesions, you want to make sure that you do not include things like an intracavitary fibroid. And if you're looking at something that's actually occupying the endometrial cavity, you want to record all 3 parameters and multiply that by a factor of 0.523. In terms of qualitative assessment, you're looking at the echogenicity relative to that of the myometrium. So in this case, you can see it's clearly hypo. This is an echogenic endometrium, and this is isoechoic, which can make it much more problematic to try and see. What about the interface? So again, we can look at the interface and say it's linear if it's well-defined, it's wavy, as you can see in this example here, and if it's irregular or ill-defined, you don't actually see an interface, which is often the scenario in people with adenomyosis. What about a non-uniform endometrium? And again, you have 4 distinct ways that it can present. So you can have a homogeneous endometrium with regular cystic spaces. You can have a homogeneous endometrium with irregular cystic spaces. You can have a heterogeneous endometrium with regular cystic areas. And then you can have a heterogeneous endometrium with irregular cystic areas. So what about the bright edge artifact? This is usually pathognomonic for something that's occupying the endometrial cavity, such as a mass or an endometrial polyp. And it's, again, very helpful when we're trying to discriminate between something that's pushing in from the outside versus something that's occupying the endometrial cavity. We're looking at that interface. Again, it can be predictive of pathology, and I'll come to some of these criteria towards the end of my talk. Now, intracavitary fluid is also described using standardized terminology. So if it's completely anechoic, it's black. If it's got low-level echoes, it's ground glass, much as you would say for an endometrioma. And if it's mixed echogenicity, you can see it's got a combination of the 2 features. When we're looking at color vascularity, you want to try and optimize your parameters. You use a frequency of at least 5 megahertz with a pulse repetition frequency of 0.3 to 0.9. And the color score is very similar to iota, so 1 meaning no color flow signal, and 4 meaning very abundant or vivid flow on color Doppler. And again, diagrammatically, you can see what 1 to 4 look like. So vascular pattern is also very predictive of pathology, and I'm going to tell you that the more disorganized and branching patterns that you have, the more worried that you should be that there is a malignant process happening. So in terms of a macro, when you're referring to a report with somebody who's got endometrial pathology, again, the IOTA group have come up with a very nice macro encouraging you to use these descriptive terms so that you can actually give a very accurate diagnosis of endometrial pathology. Okay, so moving on to the bulk of my talk, which is focusing on what the endometrium looks like. I'm going to remind you that there are obviously 4 phases. The menstrual phase, where the endometrium is relatively slender, so like this. The proliferative phase, where it begins to become a little bit more thickened, so anywhere from 4 to 8 millimeters. The periovulatory phase, where it has that nice trilaminar morphology. And then we have the so-called secretory phase, where it becomes a little bit more echogenic and thickened, anywhere up to about 14 millimeters. Okay, so in terms of histology, what's going on with the endometrium? So just to remind you, it's comprised of 2 main layers. We have the basal layer, which tends to stay intact throughout the endometrial cycle, and then you have the so-called superficial layer, which is the one that changes over the course of the cycle and is often shed. So the functional layer will thicken, the basal layer remains intact, but the vessels within it become much more elongated and tortuous. What about the postmenopausal endometrium? So again, you're all quite familiar with this. Classically, it should be thin, homogeneous, and very clearly defined. But obviously, not everybody reads the textbook. So we'll talk about pathology in a second. What's the role of 3D imaging? We know that it's very helpful for problem solving. We can reconstruct in any plane. And typically, in the setting of endometrial cancer, it can be very helpful in terms of trying to identify myometrial invasion. I'm not going to be talking about Müllerian duct abnormalities today. That's a whole topic in itself, but obviously you're all aware that it plays a great role in that. Just want to remind you of the risk of doing endometrial assessment in the wrong phase of the cycle, and I have 2 examples side by side. One of these is a polyp, and the other one is a secretory phase endometrium. Can any of you tell the difference? And the answer is, of course not, because I can't tell the difference either. So on your left, you have a confirmed polyp, and on the right, you have a secretory phase endometrium. So this is just to reiterate that you really should not be making any estimates of secretory in that secretory phase, because you'll almost certainly either miss pathology or end up overcalling pathology. So bring the patient back in that early phase to try and accurately assess. So what is the problem with abnormal uterine bleeding other than the fact that it's one of the most common presentations for gynecological visits? So we know that a large number of these patients are either perimenopausal or postmenopausal, and in the perimenopausal group, it's often related to dysfunctional uterine bleeding. Postmenopausal bleeding is bleeding that occurs in any woman who hasn't had a cycle for over a year, and it's other than expected bleeding from withdrawal following sequential HRT. What does imaging do in this scenario? Well, essentially what we're trying to do is to rule out any underlying structural pathology. So these patients should have had a clinical exam and a pap smear, but undirected endometrial sampling can be problematic, and we particularly know that because in some studies, only 60% of the cavity was sampled on DNC. So, 40% being undersampled means that you can actually end up missing pathology. So ultrasound can decide if there is either a focal abnormality or a diffuse abnormality, and then therefore triage the patient appropriately. So just a quick reminder of some of the studies that have come up with the numbers that tell us what's abnormal for the endometrium. So this is the classic meta-analysis that was published by Smith-Bindman in 1998. So to remind you, if someone is symptomatic and their endometrium is over 5 millimeters in thickness, your risk of malignancy is around 7%. If it's equal to or less than, your risk of malignancy is actually very, very modest. If you're asymptomatic, on the other hand, your endometrial thickness is over 11 millimeters, your risk is very comparable, around that 6 to 7% mark. If it's less than or equal to 11 millimeters, again, your risk of malignancy is very modest. So in effect, transvaginal ultrasound, as I said, has a very high negative predictive value. So this particular study went back and looked at these criteria to try and determine if that was still valid, because 1998 is a very long time ago. Is that still important at this point? And in fact, that they found, yes. So if we reappraise the endometrial thickness for the detection of endometrial cancer, as you change the criteria, your specificity changed. So 3 millimeters was actually considered to be the optimal threshold. Remember, though, that your specificity tends to drop off, and you might actually end up oversampling patients if you use that lower criteria. What's endometrial atrophy? So as we get older, there's exposition of the vessels in that deeper layer. That functional layer becomes very atrophic, and it leaves that shallow basalis layer intact. So initially, you may see a very, very thin endometrium, but certainly over time, as those vessels are exposed, you may see the so-called Swiss cheese atrophic appearance of an endometrium. So here we have a patient who, on transvaginal ultrasound, looked like she had maybe endometrial hyperplasia or maybe cystic atrophy. I really can't tell. The endometrium looks thickened. What is the relationship of these cysts to this patient? So she went on to have a sono, and you can see on sono, these are indeed subendometrial cysts and not within the endometrial cavity, which is clearly important in terms of whether we decide to biopsy or not. So this can account for about 75% of cases of postmenopausal bleeding. What's the approach that we take in patients who are taking HRT, tamoxifen, or the so-called selective estrogen modulators? So we image them if they're sequentially taking HRT at about 4 to 5 days after their bleeding stops. If they're taking it continuously, you can image them at any point. And then certainly if you're taking tamoxifen or SERMs, you should really use a threshold of 5 millimeters or above as well. To remind you of the impact of tamoxifen on the endometrium, unlike the impact on the breast where it's anti-estrogenic, it actually has an estrogenic impact on the endometrium, and it has a plethora of manifestations. So not only can it cause endometrial hypertrophy, it can cause cystic atrophy, it can cause polyps, and at the deeper level, it can cause fibroids, adenomyosis, a whole range of manifestations. So multiple processes can coexist as well, and we know that the risk of malignant change is slightly altered relative to that of the baseline population. So here we have a patient who has a classic tamoxifen-related endometrial hyperplasia. You can see some vascularity within that endometrium on color Doppler as well. Do we need to biopsy this? So the answer is no. Unless the patient is symptomatic, there's usually no need to do a biopsy. The American College of Gynecologists suggests that over 50% of patients will have radiological manifestations after at least 3 years of treatment. There is a progressive rate of growth the longer that they're on it, but if you stop, it'll actually begin to regress. So as I said, there is a potential risk of malignancy. You don't need to biopsy unless the patient is symptomatic. What about hyperplasia? So certainly our understanding of hyperplasia has changed in the last few years. We know that it's often related to unopposed estrogens or persistent anovulatory cycles. We can also see it in the setting of adnexal masses such as granulosa tumors. So up to a third of cancer is preceded with the diagnosis of hyperplasia, and there is a higher risk of progression as well. So in this scenario, how can imaging help? If you have diffuse endometrial hyperplasia, a blind biopsy will suffice. If, on the other hand, the hyperplasia is more focal, we know that they really should have a hysteroscopic guided biopsy because you want to direct the biopsy to the appropriate location so that you don't have a sampling error. So I'm not going to go too much into the pathology of endometrial hyperplasia. What I want to tell you is that there is a great deal of variation depending on the experience of the pathologist. There is some inter-observer variability as well. What we do know is that it's a precursor for malignancy. We cannot tell radiologically which subtype it falls into, and then the accuracy of DNC is also relatively unclear in this scenario as well. So again, hysteroscopic guided biopsy may be more prudent in the setting of focal hyperplasia. A quick word about Fibrostal. I don't know if this is still available in the market here. It's actually been withdrawn from North America. So this was used to treat fibroids, but is associated with liver failure. So it's actually had an FDA ban put on it. But if patients were taking it, there was a risk of hyperplasia of the endometrium. The reassuring thing is that there is no heightened risk of malignancy, and it is in fact a completely reversible phenomena once they stop taking Fibrostal. What about endometrial polyps? So these are essentially overgrowth of the endometrial tissue. They're on a stalk, and they're associated with dysfunctional bleeding. Thankfully, the risk of malignancy is relatively rare, and they are more common to be malignant in the postmenopausal scenario. So radiologically, ideally, you'll see a nice, well-defined echogenic mass with that nice edge interface sign that we saw. However, again, not all polyps read the book, so you may see a diffusely thickened endometrium, you may see a feeding artery, and certainly these are better appreciated on that proliferative phase. So saline-infused sonography has a much higher sensitivity relative to baseline transvaginal ultrasound, 93% versus 65% with the former. The pedicle artery sign, again, has a very high sensitivity and specificity for the presence of a polyp, and you're looking for a single vessel or a double feeding vessel with a regular branching pattern. So just moving on to the last few slides here, endometrial cancer, 4th most common malignancy in women. I'm sorry you've got the Canadian stats there, but I know it's also relatively common in this part of the world, more common in postmenopausal patients. And what we are seeing certainly in our population is a very high increasing prevalence in young women. So in their 30s and 40s, where fertility preservation actually becomes much more important. We're doing a lot of patients who are now being managed either hormonally or with IUCDs in our particular patient populations. So again, just a reminder, 5-year survival is pretty good if they're at stage 1, but as they begin to get higher stages and depending on their FIGO classification, long-term 5-year mortality does diminish. So clinical staging is inaccurate, and the FIGO classification was revised in 2009. MR was not incorporated as far as that. So what about ultrasound? Now, ultrasound actually does have quite good accuracy in terms of predicting depth of invasion, particularly when we're looking at 1A versus 1B. So just to remind you of the patterns of presentation of endometrial cancer, it can certainly present with diffuse endometrial thickening. It can present with a focal mass that's locally invasive, or, as in this scenario, which is the most scary, you can have non-visualization of the endometrium. So just to remind you, when you don't see the endometrium, don't feel happy that you can say it's fine. You really should be going on to either do a biopsy or doing an MR to try and determine whether there's something else going on. Again, blind biopsy may be acceptable when there's diffuse thickening, but if you have a focal mass, we would encourage you to do a hysteroscopic biopsy. So this is a lady who was postmenopausal who came along for a sonohystogram in the setting of abnormal bleeding. She's 78 years old, and you can see they're measuring something that looks like a thickened endometrium. And if we look at those sagittal and axial images, I'm struggling to see an endometrial echo there. I'm not sure about you, but I'm certainly challenged by those sets of images. So again, in that itself is worrisome to me. This patient went on to have imaging. She actually had a CT. You can see an extensive, locally invasive mass that's involving greater than 50% outer half myometrial involvement, and in fact, it's extending to the serosal surface. She had bilateral parametrial invasion, and she had nodal disease as well. So just to reinforce that you should not be reassured when you don't see the endometrium. So I brought you back full circle to IATA. Why do we use it? So we certainly know that there are grayscale and color features that can reinforce the risks of malignancy, just like as we do with IOTA. So we know that if we have thickened endometrium greater than a certain, if we have non-uniform echogenicity, a multifocal pattern, and a high color score, your risk of malignancy is very, very high. And again, this is just showing you discrimination between that chaotic vasculature that we see in the grade 3 cancer to your right versus that nice branching pattern that you see in your grade 1 cancer to your left. So again, this is a scoring system, again, developed from the IOTA classification. So this was a cross-sectional study that was actually using ultrasound to look at the scoring model, and again, it found a very high area under the curve of 0.9 with high sensitivity and high specificity, looking at endometrial thickness, the echogenicity, the interface, and its Doppler score. So contrast-enhanced ultrasound does indeed play a role here as well. So not only does it allow you to look at the microvasculature, but it will also help in terms of determining degree of invasion as well. I think I'm going to stop there because I'm probably way over time, am I?
Thank you, Professor Tanya, for your well-illustrated presentations.
Thank you.
And now it is time to our brilliant colleague, Professor Basma Nabil from Mansoura University. She's going to present racist in advanced